Welcome. I'd like to welcome everyone this evening to ALPS webinar. It's a pleasure for me to be here. I am Georgia Crable, CEO of the American Limb Preservation Society. Tonight's webinar, Advancing Limb Salvage Through Multidisciplinary Wound Care Excellence. We're pleased to be offering this. This is a special and unique because we are also partnering with the Society of Vascular Nurses, which this partnership definitely exemplifies the mission of ALPS to prevent or to end preventable amputations through multidisciplinary teams. So we're really excited about this partnership and this webinar this evening. For those of you who are not aware of who ALPS is, we are a multidisciplinary medical association and totally based on ending preventable amputations through multidisciplinary teams and work. We have conferences such as DEF CON and Diabetic Foot Update, and we also have partnerships around the globe right now where we're also spreading the word of multidisciplinary practices and care in limb salvage work. If you are not a member and you would like to become a member, you can join. We run these specials. You can join this evening for just $1 using the code WOUNDS. So please, if you have any questions, reach out to us. If you would like to become a member, please, this is a great opportunity to do so. And check out our website and reach out to us if you would like to get involved. So right now, I would like to introduce to you, it's my pleasure to introduce to you Allie Baird, who is president of the board for the Society of Vascular Nurses.
Thank you for the kind introduction, Georgia, and apologies that I'm sitting here with my child trying to pitch hit parenting. But we are so happy to be here tonight on this webinar and collaborate with ALPS. As we all know, American Limb Preservation Society and Society of Vascular Nursing, we cannot care for these patients alone individually. We need to work in collaboration, multidisciplinary with physicians, nurses, APPs, coordinators, you name it, to care for the patient and the patient continuum. We're so proud to not only be on this webinar with you all, but just to have obviously uniting forces across our societies. And we're looking forward to kind of what we can do together, what we can accomplish for this patient population and for the future. So thanks for having us.
Thank you, Allie. I think our next presenter, we have Dr. Joseph Mills.
Thank you. It's a real honor to be here. I'm coming to you from Houston. I have to enter. It won't let me advance. I have no conflicts of interest related to this talk, and any consulting I do are for devices or drugs that aren't on the market yet, and all the funds go to Baylor, not to me. Next. Yeah, I'm going to start with a dose of reality, but I won't end up being negative. I will end up being positive. So I'll start with a dose of reality. So at last year's DEF CON, this data was presented, which is pretty up to date. So there's between 5 and 600 million people with diabetes. At any one time, there's about 18.6 million people with diabetic foot ulcers throughout the world. About 1.6 million of them are in the United States. And the lifetime risk for diabetic foot ulcer is almost a third. And about half of them will become infected, and ultimately 20% end up in amputation. So it's a formidable problem. And when they presented this data last year, I was skeptical, but this is from OECD international data. And the US actually has some of the highest rates of limb amputation and hospitalizations for diabetic foot ulcers in the entire world. And I was kind of skeptical that the data wasn't collected correctly. But this work here was recently published by Panos Kougias and Shireen Sharath, who used to work with us at Baylor. It's a national database, and they followed it from 1993 to 2021. And what they found was up until about 2010, amputations were going down in this country. But since 2010, there's been a shift. And if you look at these curves, these are major limb amputations only. So in red is above knee amputation, and in the dashed blue here is below knee amputation. So rates have actually been rising for more than a decade. This is kind of alarming. So I'm going back. This is an older study, and the reason I put this in here is the following. This is from the Dartmouth group a few years back, and they looked at amputation rates throughout the country versus what they called vascular activity. which they defined in different ways. So A here is inpatient revascularizations. B is inpatient open surgical revascularizations. C is endovascular revascularizations. And D is just doing vascular testing of some sort, diagnostic testing. And what they showed was there was pretty good correlation for all these types of vascular activities that as they increased, the amputation rate went down. So this is one of the arguments why vascular surgery should be involved in the care of these patients, is because part of the effort to reduce amputations depends on recognizing patients with ischemia and being able to correct that variable. But that's not the whole story. It's not, there we go. If you look at the impact of intensity of vascular care, this was published by Sazimsky. It was in 2024, so it's pretty recent. If you look at the data, it shows that we're not doing a good job. So about 63% of people who undergo an amputation had no revascularization within the previous year. 92% of those that did not revascularize didn't even get an angiogram to see if there was something to revascularize. And then about almost half received an above knee amputation. So this is not the direction we want to go, but it's the direction we've been heading in. So one thing you'll see, and there was a big New York Times article a few years back that showed about overutilization of procedures. And I think the point is that we're doing more and more procedures in this country for vascular disease, but we may not be doing them on the right patients. So this study from 2022 showed there was a huge increase in hospital admissions for PAD and CLTI, but the hospital outcomes were poor, and we were doing more and more procedures with poorer outcomes. So why is that? So I made this up for a talk I had to give last year at the ADA. But if you put yourself in the place of a patient who walks into your clinic and has this typical neuropathic ulcer, what pathway they follow in this maze of healthcare largely depends on who they see first and in which setting they see them. So whether they see an ER physician, an endocrinologist, an orthopedist, an internist, a vascular surgeon, they might follow a different pathway, but in many places they don't get anything approaching comprehensive care or team care or multidisciplinary care. And at the end, they come out here either with an amputation, if they're lucky with a saved leg, if they're still luckier, they're ambulatory at home. But some of these patients don't make it through the maze and they die before they get through it. So how can we improve that? So two things that I want to point out here to get towards the end of my talk is one is there's huge disparities in care. And one of the reasons I moved to Texas 11 years ago from Arizona is this. It has parts of Texas have among the highest amputation rates in the country. And there's numerous studies around the globe that show that there's regional variation in patient care and patient access to multidisciplinary team care and foot care. This is from Samantha Minch, who's part of our ALPS group that looked at regional variations in care. So getting access is a problem. So people who need revascularization often aren't almost receiving it. But the second point I want to make is that revascularization, even though I'm a vascular surgeon, is only one aspect of caring for these patients. And it's not necessarily even the most important. It's necessary in some patients, but the biggest thing that's needed is multidisciplinary teams. So this was a study that just came out. So our group combined our data with Dr. Kate McGinnigill from North Carolina. I don't have time to go into it, but there's a Wi-Fi staging system. So basically you stage the limb based on severity of the wound, severity of ischemia, and whether or not there's a foot infection and how severe it is. And the lower stage patients actually do better if they get multidisciplinary care first and delayed revascularization. Now, that's not true for the higher stage patients. The stage 3 and 4 patients do better with revascularization up front. But a lot of patients present in these earlier stages, and this study emphasizes that their care is best when it's done part of a multidisciplinary team. And a lot of these patients with lower stage wounds really need really good offloading and effective multidisciplinary team care and don't need upfront revascularization. So what can we do to make a difference? That's why this talk is being given tonight to this group, because you all help us with these patients. And I was past president of the SVS. So one of the things we have done in the SVS is started the Vascular Quality Initiative. This is voluntary, but it's a patient safety organization. And there's now over 1,000 peripheral vascular interventions in the Vascular Quality Initiative. So these can be analyzed to compare your unit with different units in the country, to compare different parts of the country. And this isn't meant to punish anybody. It's not punitive. It's meant to improve care. So if you recognize there's certain regions or certain hospitals that seem to be getting better outcomes, we have regular meetings to try to discuss what's different about the pathway in that institution, and can that be replicated somewhere else. The second thing we work on is part of the International Working Group, also the European Society for Vascular Surgery and the Society for Vascular Surgery, is develop multidisciplinary guidelines. So these have been published in all the journals you see here. The global guidelines in chronic limb-threatening ischemia are just being redone. And Dr. Armstrong and I and Dr. Conti and others you may know are part of that effort. And finally, I like this analogy a lot. So I love to visit Amsterdam and Holland, and they have a different healthcare system than we do. And when you think about the tidal wave of diabetes, so what's changed in my career the most is the overwhelming number of patients that have diabetes, which is the biggest risk factor for a neuroischemic foot wound. And what's my analogy with Holland? Well, Holland faces the North Sea. And the North Sea is incredible because it's about 50% of the Netherlands is below sea level. So how do they stop being flooded all the time? So the analogy I would use is shown here. So one thing you can do, if you look at the physiology of waves or the physics of waves, if you try to build a huge giant wall to stop the wave, that's not going to be effective for diabetes. It's going to take too long and the wall will get knocked down. And what the Dutch have described is this wide green dike. So instead of making a big wall to block the wave, you have a series of layers with green interspersed, and this blunts the wave. So we're going to have this big wave of patients with diabetes for the next decade or more. We need to build a high-risk referral system. We need to have high-risk feet go to podiatry, high-risk PAD go to vascular, and all these components of care need to work together. We can reduce the volume, but that's going to take time, and that's preventive efforts, and that's where the ADA, SVS, SVN, and American Heart need to work together. And then if you look at the system of canals that exists in Amsterdam, for example, we need to direct and control the flow of patients so that the canals flows directly to multidisciplinary team, and we build bridges between teams so patients can connect easily. So the final slide I have here is something I just kind of made up the last few days, is what can we do together with the SVN? The mnemonic I have is ACT UP. So what does that mean? Advocate locally, nationally, globally, however you can, to raise awareness about this problem. So once every 20 seconds. So probably during this short talk, about 20 to 25 patients throughout the world have lost their leg because of diabetes. So advocate for these patients. Care for them. Everybody involved in the care of the patient, when they see a patient with diabetes, the sock should come off, and you check the foot, protect the foot, and refer the foot if there's a wound. We can teach each other. So that's what the purpose of these webinars is. We teach each other so that we can better teach our patients and their families and caregivers. When we teach, we increase our understanding. So when we work with different components of the healthcare system and different specialists and different types of practitioners, we can teach each other, and we all see different things. So we need to understand the disease better. And finally, we need to promote multidisciplinary teams and all the people that are involved in care of these patients in order to achieve a better outcome and reduce amputations. So I always end, this is our STEP team, Save the Extremity program at Baylor. We have 4 podiatrists now and 5 vascular surgeons that focus almost all their efforts on limb salvage. And I'll end with a plug for ALPS. So ALPS is a non-for-profit group that tries to advance the thought that we want to try to prevent all preventable amputations within the next decade. And with that, I'll close and thank you for your attention.
All right. Thank you so much, Dr. Mills. I love the maze analogy as well as the canals analogy. When we talk about these programs, as you mentioned, and the research being there, we have to be absolutely relentless. So as we talk about coordination of the services that Dr. Mills referenced with regard to creating those multidisciplinary teams, and I've even tried to go beyond that and call it a transdisciplinary team, because we all know, as Dr. Mills said, that we can have different disciplines, right, seeing these patients, but if we're not in either physical or at least verbal proximity to one another and having conversations, even multidisciplinary care sometimes is substandard. So we really need to be aiming toward that transdisciplinary care where we're transcending our own disciplines to meet each other outside of there and center on the patient. So with that, I'm going to talk about some of the lessons that we learned just very briefly. What I want to emphasize here, if you can, next slide, please. If you look on this call, so 3 of us on this call this evening all came from Toledo, Ohio. So oftentimes I know I've been on webinar sessions, lectures like this, and I'm thinking, man, I am a nurse practitioner from Toledo, Ohio. How in the world can I do this, right? You look at some of these bigger centers and it's a little bit intimidating. So I want to emphasize that even in your own environments, all of these programs and all of our efforts look a little bit different depending on the resources that you have. You may be more centered around podiatry because you have podiatrists that are engaged or champion. You may be centered on vascular surgery. You may be centered on ID or plastics or ortho or, PM&R or ID. Every program is going to look a little bit different. And I feel that as long as we are relentless in that coordination and what Dr. Mills was talking about, we can make a difference at every step. So I'm going to talk about 4 of our critical pitfalls as we were building our program in Toledo, Ohio. 2 of us have since moved on, but I take these lessons with me everywhere that I go. Next slide. So the first is that we oftentimes look at limb preservation within surgery, within the hospital, the toe and flow model. We focus heavily on what happens with the patient, either in the acute care setting or in the ambulatory setting. And I think it's really important. And one of the things that we learned early on in our program is that the majority of wound care and the majority of surveillance for these patients is actually happening in the community. It's happening by their family members who are oftentimes not only scared and vulnerable, but obviously not trained, or it's happening with home health agencies or in extended care facilities, subacute rehab facilities. So I think that one of the things that we learned early on is building systems and teams around those settings that aren't immediately available to us. So very early, we worked relentlessly with our home health agencies, trying to pull in engaged nurses, even if it was just 1 or 2 nurses from an agency, making sure that we cross-trained them, that they understood both the vascular and the wound care, the podiatric, that they understood kind of the full scope of things so that they could monitor those patients and escalate and then get to us when we needed it. So we had to have a clear and good escalation pathways for those professionals who, they're doing all kinds of things when they're going into the homes to see the patients. Oftentimes they're in vulnerable, unsafe situations themselves. So making sure that we armed them with at least basic knowledge and a clear communication method to us so that if they were in the home with the patient or if they were in the extended care facility and they saw something that concerned them, they had a direct line to get to us so that we could reach them easily and get the patient taken care of. A lot of that takes standardization, having care pathways and algorithms. But as Dr. Mills mentioned, again, these patients are traversing a very complicated system. Oftentimes those black and white algorithms don't work. So we also have to have support and communication because there's so much gray area. And that's where the need for coordination comes in and involving the family members in the community, doing lectures at senior centers, trying to reach patients where they are, churches, so that you can really pull in entire communities around these patients, not just focusing on the acute care. Next slide. One of the other things that we realized is that we had these silos among settings. So even as we were pulling in our community, we were very fragmented within our own institution and our own disciplines. So in our institution, the role of the advanced practice provider was really crucial. We used our advanced practice providers, obviously, as very autonomous and independent practitioners who could see patients, improve access to clinics, allow surgeons to be in the OR where they are best using their talents, but also serve as coordinators and liaisons between settings. So our APPs would go into the community and do education, into the extended care facilities, work with the home health nurses, and really be those bridges and liaisons. If you don't have the luxury or the fun of having an advanced practice provider, we have also employed and worked with LPN and RN champions similarly, where they can be doing a lot of the patient education, helping book surgeries, helping to coordinate the patient after surgery, making sure that the extended care facility gets the patient where they need to be on time, that they can help escalate care if needed. Even medical assistance, whatever resource it is that you have, taking those engaged individuals and making sure that within your own microcosm, you're bridging those gaps with champions. These became highly trained navigators for us. So these individuals, be they LPN, RN, or APPs, then learned not only the system, but they learned complex care methods and, could really function and feel empowered by their own role. They got to know patients, they got to know families, they felt very engaged and invested. So making sure that you don't silo or fragment your own systems within your system is also very important. Also making sure that you do have access to a cross-trained wound clinic staff, that the wound clinic staff, as these patients do have tissue loss, diabetic feet, mixed arterial venous leg ulcers, that your wound clinics and vascular clinics and podiatric clinics kind of understand what each other does and that they have that connection and communication among themselves as well. Next slide. So you can see that we're kind of along the same vein, right? These systems are so complex that there are so many opportunities for patients to fall through the cracks. Another thing that we found is that when we were in our rural institution and or some of our satellite settings, even within the extended care facilities, we didn't have access to vascular surgery or interventionalists, IR, who could do these procedures all of the time. So we know that time is tissue, right? That proximity is really non-negotiable. So if you're in an institution or a setting where you don't have direct access to a limb interventionalist, a vascular surgeon, phoning a friend or making sure that you have the courage to pick up the phone and cold call and say, hey, we have these patients coming in, or we're in a wound care center and we're finding a lot of CLTI, we're treating diabetic feet, and trying to build those relationships so that when that does happen, you have a vascular surgeon and or IR and or interventionalist at your disposal, that even if they're not close, you have somebody that you can get them to. That co-location of teams is really important. Verbal communication is okay, but again, when you have the physical proximity to one another around the patient, be it in the inpatient setting, like I said, we had APPs that went out to the extended care facilities, trying to make sure that we bridge those gaps physically. But that access to vascular surgery is really crucial in these situations. Next slide. And then the last thing is that oftentimes we rely heavily on 1 to 2 services, right? And as Dr. Mills mentioned, there are so many different services that are caring for these patients at any given time. They're diabetic, we need endocrinology. Our patients that do end in amputation, we want to save their contralateral limb, we need physical med and rehab. Osteomyelitis, we need infectious disease. If we're doing complex procedures, plastics for flaps, podiatrists, vascular surgery, case managers, social work. So making sure that as we build these programs or we start to build these teams around patients, we don't narrow ourselves to 1 or 2 providers. And we really seek to find, even if it's just one individual, one nurse, one physician in these other fields, PT, OT, that we can rely on, so that when we have those really complex patients that need multi-services, we have at least one person that we can give a call, phone a friend, and get some help. Next slide. Okay, so essentially these are kind of the 4 things that we learned. And as Dr. Mills said, they center on coordination and trying to be that safety net for the patient when they fall through. But what I want to emphasize again is that no matter the size of your institution or the location of your institution, every effort helps. So even if you are a champion, if you're engaged, you're passionate about this, every person that you reach is one more person that you've reached. And then if that person reaches one person, that person reaches one person. It takes a lot of time, it takes persistent, but really over time, you can build strong teams around patients and families. Like I said, in my first experience in Toledo, it wasn't our institution that provided us the majority of support. It was actually our community. And it was our community that built our program. So focusing on what your strengths are and then building off of them is really imperative. Next slide. And with that, I will turn it over. Dr. Nizal.
Thank you very much, actually. And first, I appreciate being part of this group. And I will start by saying my conflict of interest here, that I'm a vascular surgeon, which is a good thing and a bad thing. Well, let's go to the first slide. Yeah. Next slide. So there are the pathways for amputation we've been talked about now so far by Dr. Mills. Karen also touched on it. And in itself, it is the problem actually with limb preservation. It is not one pathology. It can range from a simple diabetic infection to very complex disease in a patient who has multiple factors, like the patients I saw today, vascular, arterial, venous, diabetes, vasculitis, and it's a mess, and the ulcer been there for 12 years. And the problem that it been turned from one hand to the other, and nobody knows what's the next step. Next slide. When we talk about vascular disease, it is very well-defined area, which means if the patient have ischemia, whether it is severe or it is mild ischemia, it's a pathway for management. But as I say always, we can accept moderate occlusion or stenosis in a patient with claudication, but if the patient has diabetes and an ulcer, that moderate stenosis is not acceptable. You need to give the patient the maximum blood flow and the control of infection to prevent the amputation. As Dr. Mills mentioned, the amputations are increasing actually. We looked at the Trinetics data till 26 over 9 years. The number of interventions have increased exponentially, especially the endovascular interventions, where financially it is gratifying, but the problem, the number of amputations increased. So endovascular interventions or even vascular interventions in general are not preventing amputations so far. Next slide. We in vascular surgery have a number of ways of doing improving the blood flow from endovascular to open surgery. But unfortunately, we are to some extent don't have the knowledge or even the stamina to pursue other ways of healing wounds. We think once the blood has been restored, the patient should heal himself. That's not the case actually. We hardly look at other causes for non-healing, or we turn the patient loose to his primary care physician, and at the end we end in a problem-related lack of proper care. Next slide. So the limb preservation pathway is a very long way. It is starting by the suspicion that there is a problem, especially vascular problem when I'm talking about here, until you prove it. And it's not contraindicated to examine a patient. Unfortunately, the last thing people do, put their hands on the patient. We resort to technology always, avoiding examining the patients. And we should have a low threshold for revascularizing those patients to improve the blood flow to the maximum before we really start doing other things. Delayed referrals, worsening ischemia, added infection, ended amputation, and a high mortality, as was mentioned at the beginning of this seminar. Next slide, please. And here is the worst part of the multidisciplinary foot team. We need a foot team which is multidisciplinary, but we so far did not define who is the gatekeeper, and everybody thinks if a podiatrist is a gatekeeper, amputation will be prevented. Plastic surgeon is the plastic surgeon, vascular surgeon is vascular surgeon, and so on and so on. Unfortunately, the gatekeeper is the one who is going to examine the patient in every aspect related to non-healing, from diet to infection, revascularization, and the person who has good connections with every aspect of healing, from orthopedic, podiatry, infectious disease, etc., etc. If you look at actually one of the problems that we have, and Dr. Mills again started talking about it, we have so many organizations talking about wound healing and wound care. But if you look at it really in a very critical analysis, you find actually they don't agree on many things, and they are talking about different aspects of the wound healing rather than collective knowledge of the aspect. For many reasons, we cannot go through it now. Next slide, please. So the gatekeeper is the one who knows all and reaches all. So we need to assess the patient from the minimal assessment to the highest assessment, including the sugars and others. And then we need to control the blood pressure, prescribe different medications, offload the patient when needed, improve the blood flow when needed, surgeries for improving the road from one part of the foot to the other. All these can never be done with one specialist, one person. It is one of the areas in medicine that we cannot define the specialist in it, and we have no real good degree in wound healing or board in wound healing. People are trying. Hopefully, it will be fruitful down the road. But we need to define wound management in a better way in order to agree on how to manage those patients. Nowadays, we focus on procedures, and perhaps the procedure should play a major role, but is not the only role. Next slide, please. So the messages for a gatekeeper that we need to remember: amputations are largely preventable with early identification and coordinated care. And we have to work on the coordinated care, and we have to define and identify those patients very early. The gatekeeper is the person who knows the red flags: no blood, no healing, no offloading, no healing in some situation, and so on. Prompt vascular intervention is important. You cannot delay intervention until infection is much worse. Time is critical for critical limb ischemia. Vascular surgery alone is not sufficient. You need to involve others and other services. The gatekeeper is the best coordinator of care who knows more about different parts of care, and they have to manage the whole rather than the whole. And I think stop here. Happy to hear from others.
I think it's my turn. Good evening, everyone. And actually, I'm going to be taking the multidisciplinary limb preservation model from a different perspective. And I think by now, all of you, or maybe even before now, knew the importance of the multidisciplinary limb preservation approach and its impact on the improved outcome for this group of patients. So accordingly, I think it's as important as knowing about the pathway and the treatment algorithm. It is important to implement that in our training program to the upcoming generation so they can be able to carry that out and provide such approach and service to the ever-growing patient population. So next. So what is the educational vision behind that? So, implementing a multidisciplinary limb preservation model in training, one of the important vision items is to make your trainee think beyond procedures. So it's not just about debriding the wound or establishing the blood flow. It's a more complex process that going on in this patient or group of patient that need to be addressed as a whole, not just the procedure part. So that thinking process of thinking beyond procedures, a very important vision element. The other part is the early recognition of limb threat. And I can't emphasize that more. And I think Dr. Nizal and Karen kind of pointed and highlighted this item very importantly as time equal tissue. The third element of the vision is develop some competence in wound science and wound care. It doesn't matter who you are. If you are the first one to see this patient, you need to have some at least basic understanding of how handling these wounds. And the fourth element of the vision is develop that multidisciplinary approach, which develops some team leadership skills or skills of becoming a good team player. Next. So what are the core components of such training? I think, there's a lot for the trainee to learn, but if we want to classify or break that down, I think there's four main elements. Number one is to recognize there's a problem, by physical and history, and, understand or recognize there's an issue of blood flow as contributing to that. So having some sort of understanding to the vascular diagnostic test is important. And it depends on the trainee background and their specialty, maybe understanding the different revascularization pathway, especially if they're a vascular surgeon or intervention or radiologist. The other element, as I pointed out earlier, is the wound management. Have some understanding behind the wound science, the wound bed preparation, surgical debridement, offloading principle, infection control. And more important is the understanding of this is a multidisciplinary team approach. It's not just one person who can do it all, you know. As I mentioned, this disease process that affecting this group of patient, it's a systemic process. So this group of patient may have uncontrolled diabetes, may have some sepsis going on, may have, you know, need some complex reconstruction and even rehabilitation after that. Next. So what are the models that we can use to implement these different core components? I mean, that depends on the status of your institution. If you're in an institution that have a well-established multidisciplinary limb preservation team or clinic, it can be easy just by plugging the trainee in that team or clinic for a rotation that, you know, span a few weeks or so. But I think it becomes more challenging if your hospital or institute does not have that integrated, well-established pathway. If you're thinking about it, I mean, it's always, you know, again, as we kind of emphasize on the importance of such approach to establish it, but if you're in the process, or if you don't have it yet, it doesn't mean you don't need to implement that idea in the, you know, the training of your, you know, trainee. Always have them or provide them with opportunity to rotate in this different specialty that contribute in the management of this patient. You know, if it's possible, you know, for example, as a surgical trainee, they can have spent some time with vascular, some time with wounds, some time maybe in the podiatry clinic or the plastic clinic to just get an exposure and idea about what's going on here. And more importantly, next, to implement and emphasize the idea of the multidisciplinary team approach, whether that's through conferences or even during the didactic, maybe developing some in-services training, a simulation workshop where the trainee can get exposed to different things, whether it's a wound products or, you know, some didactics from other specialty that, you know, involved in this group of patient management. Next. And, you know, it's not one size fit all. You know, there's different opportunities for implementing and emphasizing the idea behind the limb preservation model or the multidisciplinary limb preservation model based on, you know, the background of your trainee. For example, for general surgery trainee, you can always emphasize the idea or the training behind recognition of diabetic foot infection, how to triage them, assess them, how to control sepsis, how to pre-op optimizing them, how to implement principle of debridement and infection control, and when to call vascular by understanding the different, or at least have basic understanding of the different diagnostic tests that can point out there's an issue of blood flow here that need to be corrected. Next. On the other hand, if you look at the training opportunity for vascular surgery trainee, maybe it's a little bit more into the revascularization aspect. So they need to be familiar with the CLTI decision-making models like Wi-Fi classification, for example. They need to understand more about the open and endovascular revascularization options. And, you know, they need to understand how to assess for blood flow in more depth. But it's important for them to get some understanding on the wound care principle, how to perform minor amputation for infection control to save the rest of the foot. Next. And as important as it is to understand how to conduct and implement the limb salvage or the multidisciplinary limb salvage model for your trainee, it is important to assess that model. So it's important for them to get involved in the different QI activities like M&M and QI project to see how their program is doing or what's the outcome of the patient population that they're serving. It's as well of importance for them to be familiar with the different limb salvage outcome metrics like, you know, major amputation rate, amputation-free survival, readmission rate, length of stay, and patient satisfaction, and so on. So I think, you know, the whole idea is it's not just about performing the multidisciplinary limb preservation model approach, but try always to remember that need to be taught to your upcoming, you know, provider, regardless of their background, as long as their provider will be, you know, managing or encountering this group of patient population. I think that's the end of my part.
I think I jump in here. So my name is Nora Dunlap. I am a vascular nurse practitioner in Baltimore, Maryland at a tertiary care medical center. Um, I started as a straight vascular surgery NP, and then the opportunity opened that I could do some inpatient and outpatient work. And once I kind of left the hospital setting, I realized, wow, there is nobody that's dealing with these wounds. And patients can't get to a podiatrist appointment, a vascular appointment, and a vascular lab study or a CAT scan appointment all in the same week, right? There's mobility issues, there's lots of problems. So I kind of fell into this role of limb salvage. And so I thank you very much for the opportunity to talk to you guys about it. The way that we kind of take look at patients is if you have a wound or something, you have a vascular problem until we can prove otherwise, because something is obviously going on. So we're going to talk a little bit about that. So peripheral arterial disease and chronic venous insufficiency are the leading causes for chronic non-healing wounds. 25% of diabetic patients are going to get a wound. Dr. Mills did a great job kind of going over the stats earlier on. So what I really had to work on since I became kind of a wound NP on the fly was really figuring out, how do I tease out what the problem is? Is this an arterial problem? Is this a venous problem? Is it a mixed problem? Is there infection? Because you have to kind of tease out what is the root cause in order to care for these patients. The stats are a little staggering. Right, these patients, wound care can reduce major amputation rates by up to 85%. And that, especially as nurses and APPs, that's something that we can directly impact these patients for. And shockingly, what do I find is that my patients have more than one problem, right? So a lot of them are mixed arterial and venous. So how are you going to balance somebody who has poor blood flow going to their feet, but also has so much swelling that their tissue would never be able to come together, and somehow get control of that bioburden within the wound? So that's what I was going to talk a little bit about with you guys. Dr. Zal talked about this. Some kind of looking at ABIs, an ankle brachial index, is a great kind of starting off point. If you have an ABI kind of a 0.7, 0.8, I describe it to my patients as, if we were grading you in school, 100 is where we would love you to be, but you probably haven't been there since you were 18 or 21. So what do we have to work with now? If you're a C or better, we can probably work with that, but less, depending especially on the size of the wound, you're going to need to get more perfusion, or that wound's never going to be able to close. And especially when you're looking at somebody that has an ABI of less than 0.4, or somebody has a toe pressure of under 40, they really need an intervention. And time, as Karen said, time is tissue. So if you don't get blood flow to that wound and also have a plan for that tissue with your podiatric partners, as soon as you kind of flood that wound also with a bunch of blood flow, you're going to wind up having a bigger problem, because right now all this bacteria has all this great oxygen and it can multiply. And then you're going to have a kind of almost a worse infection if you don't have a plan, which is why, kind of, as everybody's talked about, a multidisciplinary approach with lots of communication, because you can't kind of have one step until you have a plan for the next step and then the next step. The other thing I would like to say about ankle brachial indexes is, just because you get a number, actually looking at the waveform is helpphal. A monophasic waveform, which just kind of looks like a squiggly line, that's not great perfusion, as opposed to if you actually have like a triphasic waveform. And so I think that sometimes people will kind of write off, oh, somebody has an ABI of 1.1, like, oh, that's great. Well, it's a diabetic patient and their vessels are non-calcified. So actually they have a really big problem because their toe pressure is 40, but nobody actually clicked the button to look at the imaging. And if you look at that imaging, not just read the radiologist or vascular lab report, I think you get to know a lot more about the patient and their actual vascular health. When you're looking at the tissue piece of it, right, the time principle talks about removing kind of non-viable tissue and controlling for infection, managing the moisture balance, and then kind of preparing that wound and the wound edges to be able to close. Most of these patients need weekly wound care, which is, again, where this kind of multidisciplinary piece comes in, is how is the patient going to get to all of these appointments? So a lot of times what I have to do with my group, between vascular, outpatient rehab, the wound center, me, getting them in for an angio is we all have to kind of take a week, and communicate. And so sometimes somebody has to do a little bit more on their end because the patient can't get to the next place. Because really the wound care, the debridements, and even things that people don't think of, when you have a wound, patients go, oh, well, I can't get in the shower because soap and water is going to get my wound infected. No, soap and water is great. Soap and water is wonderful. Even just washing the wound is a benefit for the patients. Recognizing infection, biofilm is going to be on any open wound, but kind of being able to look at those wound edges. Is there erythema? Is there redness? Does it just look like a little bit of fibrotic tissue? Is there pus? Is there something probing to the bone? A lot of these, diabetic patients have such bad neuropathy that they're not going to realize that they've been walking around on this chronic wound that's actually probing down into their bones. Infectious disease can be wonderful partners. Again, unfortunately, then one more appointment that the patient has to get to. So how can you kind of partner to figure out a way to loop an infectious disease via telemed while they're sitting there so that you can also take down the wound and show, the ID people what's going on so that they can come up with a plan. So sometimes really that out of the box thinking is what's needed. And I do think that as nurses, that's actually where we really excel. Matching the dressings to what's going on with the wound. The venous ulcers are going to need a lot of moisture, kind of foam dressings. High exudate wounds are going to need a lot of, ABD pads, Draw-Tex, something to really absorb all of that and get that wetness away from the tissue. Lots of people see, if you've got eschar, kind of that dry, dark on a toe or on something else, if you don't have blood flow, that at least is kind of a stable scab for the moment, right? You can work a little bit on the blood flow first and leave that for debridement later. So kind of looking at each wound, there's no cookie cutter answer for any of these wounds. For the venous wounds, you're going to need compression, but then as I said before, a lot of patients don't have only one thing wrong with them. So compression is wonderful, but it's not wonderful in patients with severe PAD where you're actually going to compress the little bit of blood flow that they're getting into their lower legs. So again, looking at the ankle brachial index, figuring out how much compression can they actually tolerate, and working with the patients also on what they will actually try to get on, because compression is not easy for patients to actually get on, especially elderly patients need like wraparound compression stockings or lymphonomatoc pumps at home to try to help some of that swelling. Pressure, this is where the podiatric surgeons really can come into great role is figuring out how to offload these patients. So total contact casts, X-fixes, a way to offload the wound, because if pressure is continuously on that wound as the patient's walking, it's going to be extraordinarily hard for that to heal. The one piece to think about though is whatever they're going to put on the patient going to impede the vascular flow. So we actually started doing a limb board. I'm actually missing limb board tonight, but it's a multidisciplinary Zoom meeting where we talk about kind of where's the perfusion, where can you cut, where are they going to heal with our podiatric and vascular surgeons, advanced practice providers and nurses, making plans for these patients, because as Karen and a lot of others have said, right, it's communication, constant communication, especially because the patients continue to change day by day. There's advanced therapies that can be used kind of after you have optimized their vascular status, you've controlled for the infection, you've managed their leg swelling, because a wound is kind of considered chronic if after 4 weeks, once all of those things are managed, it hasn't closed by about 50%. And this could be a whole separate talk, so I'm going to keep going. The team, you need all of the team, as everybody has said. But the patients, it is a lot for them to handle. So figuring out a way to really offload their stress, their confusion, and makes things as streamlined has been, in my experience, the best way to really help these patients succeed. So giving patients checklists, kind of, this is what you need to do every day. These are the signs and symptoms of what to call. As Karen said, getting the family involved, the community members involved, right? Home health is not always available, especially if the patient's on the outpatient setting. And then setting these patients up for, let's the wound closed. That's wonderful. They have vascular disease. They have diabetes. They need to keep seeing the podiatrist. They need to keep coming in for routine screening to make sure that something doesn't happen. And my patients know the biggest thing is that if you have pain that wakes you up at night, or if you get a cut on your foot, you need to message me. That's the down and dirty, and they seem to be able to remember that pretty well. So teamwork, teamwork. The team that rounds together saves limbs together. And thank you all very much for the opportunity. And I think we have time for questions.
Thank you, everyone. I think we had one question, and it was about a couple of questions, actually. One of them, what is the best tool for communication for multidisciplinary teams for high-risk patients when they are not physically in the same location? So I'll let any of our panel wants to take a look at that.
So I've been trained that you never want a system dependent on an individual. But for us, unfortunately, our systems oftentimes don't support the needs of the patient. So for us, it's always been, like the hot foot line type concept is having a phone number that they can call verbally that will be answered at all times. And who answers that call is dependent upon the institution. If you have a limb preservation fellow that's on call overnight or your RN navigator during the day. So we have always found that verbal communication is best. I don't know how others feel about that.
If I say really, the phone is the best way, Epic Chat and others not working. But I guess actually you need a person who will coordinate everything needed about those issues related to wound healing. So not consulting and moving, it is really establishing a plan on the spot. So everyone who is needed is involved rather than just sending an email or something.
Yeah, for us, it's different depending on inpatient or outpatient. In inpatient setting, if there's a podiatry consult for a foot wound, then they automatically get a vascular consult and vice versa. So now the hospital pretty much knows to call both, but if they don't, then whichever podiatrist is on call with whichever vascular surgeon, they both see the patient, and we kind of put the patient into three groups. They have normal blood supply, and this is a neuropathic ulcer that may or may not be infected, in which case podiatry takes the lead on that patient. Or they're obviously ischemic and they need revascularization first, and the foot debridement can wait. Or we're not sure, they're somewhere in between, and we try to decide, do this patient need an extended hospital stay, or can we give them a little bit of care, get them better, send them out and follow them as an outpatient, decide what to do next. For the outpatients, it doesn't matter where they get referred to podiatry or vascular, they get Wi-Fi'd, and then those are off and run. We have NPs that are assigned to podiatrists and vascular surgeons. That works pretty well. I agree that my chart and Epic don't work quite as well because not everybody can check that all the time. So we have a direct phone conversation. Same thing with consults. We'll share images and say, I just saw your patient on the 5th floor and this is what I'm thinking. And if we can't resolve it by one or two texts, then it's a phone call.
Yeah, I think I will just echo what was mentioned. In our institute, we have a nurse navigator or a triage nurse who receive all the referral, and that's like a specific like number where everyone will reach out to. But it's still, if there is a patient that's a provider or a wound surgeon or podiatrist is concerned about, they usually try either to page us directly or email us, whether it's inpatient or outpatient.
Thank you. Any other questions that we can put in the chat if anyone has additional questions? I don't think so. I also wanted to comment, if we can go back to the our wounds and our membership slide, can we do that? Thank you. When ALPS started in 2021, one of the goals, it was Dr. Mills and Dr. David Armstrong, they started the organization with the idea that they wanted to set up this networking platform and a way for the people who are attending DEF CON to be able to communicate throughout the rest of the year. And so again, by joining us, put wounds in, by joining us and becoming a member, you can actually be a part of this networking platform. And it's a great way to reach out and see what other people are doing. And you can communicate directly with other members and who are doing limb salvage work around the country and around the world. So want to plug that one more time. And I want to thank all of our presenters tonight and our partnership with SVN. If you will be attending SBS and SVN in June, we will also be doing a session with them. We're super excited about that. There we go. So I think we're right on time. Thank you so much for everybody for joining us tonight. And thank you to our presenters. Appreciate it.
Thanks, everybody.
Thank you.
Thanks. Have a good night.
Awesome. Even on time. That was great.
Yeah.
Well done.
Thank you guys so much. Thank you, Dr. Mills. We really appreciate you being here and
Ellen,
advocating
thank you.
and supporting us. Yeah,
No,
thank you. And Dr. Ahmed, I really liked yours too.
Thank you.
This is a real systems problem to adjust. It's not a procedure problem. It's how do you get a system to work? And nobody's got a perfect one. But if you look at the ones that work, they all have a lot of similarities, right? They're not identical, but the common things that make them work are common usually.
And
Anyway,
starting
thank
with
you all
people
for
who
doing that.
care. Yeah.
Yeah, you
So
need people
thank
that
you.
care and can work together and talk to each other.
That's right.
Anyway.
So yeah, thank you so much, guys. Appreciate it.
Thank
Take
you.
care.
We'll
All right,
see you
take care.
guys. Bye-bye.